I'm Raczka, and I'm president of the British Psychological Society, and I've been working very closely with the BPS's Policy and Public Affairs team and also members to understand the details of the 10-year health plan and ensure that the BPS members' views are represented in the ambitions of the plan as they are delivered. I'm really pleased to be chairing this really important webinar today, and it's great to see there's so much interest in this topic from such a wide variety of our members and also the psychological professionals. The plan for this morning is that I will shortly share my reflections on the plan and the importance of this plan for BPS members. We'll then hear from Adrian Whittington, and Adrian is the National Clinical Lead for Psychological Professionals at NHS England. And Adrian will set out more of the key details of the plan and the key role that psychological professionals will play in delivering the plan's aims. We'll then hear from Liza Walter-Nelson. Liza is the chair of the BPS's Division of Occupational Psychology. And Liza will talk through the important role psychological professionals play in system transformation, specifically in the context of the 10-year health plan and the government's 3 major shifts in healthcare delivery. Following this, for the last 15 minutes or so of the webinar, we're going to open the session up to everybody for an opportunity to ask questions to the panelists. You'll be able to ask questions on the Q&A box, which you'll see on the bottom ribbon of the screen. We've scheduled the webinar for 1 hour and 15 minutes, and we have to finish promptly at 1 o'clock. So I'm going to keep a close eye on the time as we go through the morning and early afternoon, both for myself speaking and also for our other 2 speakers as well. So we want to make sure there will be time for you to put your questions to the panel before we end the webinar at 1 o'clock. So some reflections on the 10-year plan. The 10-year health plan is a really important moment for the NHS and for our wider health and care system. Whilst it's not the first plan we've seen that has sought to tackle the medium and long-term future of the NHS, this plan does provide a refreshed blueprint for the future of the NHS. Now, as most of you will be aware by now, the plan is centred around 3 key shifts: the shift from hospital to community, from analogue to digital, and from sickness to prevention. I'm not going to take the time today to go through the details of these, as Adrian will be covering those in much more detail in his presentations. But it's important to hold on to those, because those really do set the whole tone and frame for how the plan needs to be delivered and also implemented by ourselves as psychological professionals, as well as other people across the whole of the NHS and healthcare systems. Overall, the BPS is very supportive of the plan's ambitions, and I'm really keen to ensure that psychological professionals are key to supporting the delivery of the plan. We've seen a really significant growth in the psychological workforce over recent years, and that should stand us in good stead to play our part. The psychological professions workforce has grown by 65% from 2019 to 2024, although clearly this needs to continue if we are to keep pace with the demand. Community services, for example, have played a crucial role in the delivery of mental health care, providing vital support to people with mental health problems closer to their homes and communities. Psychological professionals are well integrated into community services, helping people manage the psychological and emotional aspects of health and illness, promoting healthier lifestyles and supporting people to improve their physical and their mental health. Furthermore, new technologies are being created all the time and have a key role to play in healthcare. And there are numerous great examples of how digital innovation has been successfully incorporated into psychological therapy. And rehabilitation, for example, technological developments have expanded the scope and effectiveness of the discipline. And finally, as we're shifting towards more preventative models of care, it'll enable the delivery of both better health outcomes for people and a more efficient health system. So psychological professionals play a major role in preventing illness and improving patients' quality of life, and will be key to observing and delivering this shift. But we do know the treatment is also essential for saving lives and managing chronic diseases. So I'm particularly pleased to see the commitment in the plan to tackling the deep and entrenched health inequalities that exist in the UK, particularly a target to reduce the gap in healthy life expectancy between regions. This will require significant investment in local public health services and a focus on delivering effective public health campaigns. I'm also very interested in the neighbourhood health centres that are being mooted for each community. They will be open for at least 12 hours a day, 6 days a week, to provide access to coordinate local services. We all heard at the budget last Wednesday the government committed to opening 250 of these centres, with 100 of these to be opened by 2030. So again, an ambitious plan there for the government to implement. Alongside this, the plan aims to deliver 24/7 neighbourhood care model for mental health services. And so far, 6 centres will be opening around the country and will bring together a range of community mental health services under one roof, including crisis services, community mental health services and short stay beds. So clearly, psychological professionals will be vital to the delivery of these services and the plan's ambitions. We're waiting for the forthcoming 10-year workforce plan, which will set out details of a new workforce model with staff who are aligned with the future priorities for the health service. We're expecting publication of this workforce plan in spring next year, and we'll be looking closely at the details of this. It's also important to bear in mind, though, that developing a strong NHS workforce does not only relate to numbers, but also to improving staff well-being to make sure the NHS is retaining staff and not losing them to sickness, absence, or from profession entirely. As people will be aware, at the BPS, we've campaigned consistently for the need for funding for wellbeing provision for NHS staff. So we were really pleased to see that in the new plan, it does contain numerous mentions to improving the working culture and environment to improve staff wellbeing. We would want to see this expertise of psychological professionals included in the development of this, and for it to feature the same focus on prevention and early intervention that is a goal for wider NHS treatment. At the BPS, we've been working hard to champion the importance and the key role of psychological professionals in national level discussions. We've also been working closely with members to understand where psychology can have the biggest impact for the planned reforms. So earlier this year, in September, we delivered a series of workshops with members, looking at each of the 3 different shifts. And some of this will be available on the BPS website shortly. The BPS have also been spearheading closer collaboration between the professional representative bodies for the psychological professionals. To leverage the collective voice of the professional bodies for psychological professionals, a new joint working group has been established to foster opportunities for joint working and collaboration, something that we feel is really important for us to be working in a coordinated and a joined up way with colleagues from other organisations. We know that psychology and psychological professionals have a fundamental role in helping to tackle some of the most crucial policy issues. We'll therefore continue to produce evidence-based guidance, advice and best practice for members and promote excellent and ethical practice in the science, education and application of the psychology discipline. So that's my sort of high-level thoughts of the implementation of the plan and the importance of the role of the psychological professionals workforce. What I'm going to do now is hand over to Adrian for his presentation on the key policy aims of the 10-year plan. So over to you, Adrian, for your presentation.
Thanks very much, Roman, and thanks very much for the invitation to be part of this session today. Delighted to be here, and I agree with you. I think the psychological professions will be really crucial to deliver the ambitions of the 10-year health plan. And it is a very ambitious plan. And so I'm in this role as National Clinical Lead for Psychological Professions. The purpose of this role at NHS England, and I hope soon to be Department of Health and Social Care, is to maximise the impact of the psychological professions for the public in line with policy. Here we have a very ambitious policy that really sets the direction for the next decade in healthcare. And it's really clear to me that we'll only be able to deliver on this ambition by working together with partners such as the BPS, such as across the psychological professions bodies, as you've mentioned, and everybody on this call. So it's great to be here, to be having the conversation today. What I've planned to cover is why we need a new care model, some of the opportunities and challenges within the 10-year health plan, and I'm going to set out what's in it in broad terms. And my sort of take on this is going to be around particularly psychological healthcare. So what are the implications for psychological healthcare and what comes next? So why do we need a new care model? Well, it's very clear that the sort of demographics of our population, and I'm taking an England focus in this talk because this is an England plan, but of course some of the same themes apply across all of the 4 nations and beyond in the developed world. And our demographic changes signal something very important for healthcare. Soon after this government took power in 2024, we saw the publication of an independent review of healthcare by Lord Darcy, and some of the sort of content of this review is set out here. We're an aging population. So if we look at the graph on the left-hand side, we see that we're now back on the uptick in life expectancy, which has been rising for some time. We saw the downturn during the pandemic, but now we're back on the upturn. So our population is aging, but sadly for those of us who are heading towards this bracket, our healthy life expectancy is not increasing at the same pace. In fact, that is remarkably static. And as the right-hand graph shows us, as we age, then on average, we will gain additional long-term health conditions to contend with. So by the time we're 85 or older, on average, nearly 90% of us will have a long-term health condition, and about a third of us will have 5 or more long-term health conditions to contend with. So you can see here there's an interaction between aging and long-term health conditions that need management and to be coped with. And if we look at mental health, I mean, what's interesting here on the left-hand side, when we look at these long-term health conditions more generally, yes, there's a rise, a significant rise in conditions such as diabetes, hypertension, which have a really significant impact on healthcare demand. But the conditions that are rising fastest are mental health conditions. And so I've highlighted in this left-hand graph depression and anxiety. And by the way, this isn't diagnosis. There's a debate, isn't there, over to what extent we're underdiagnosing, diagnosing right, or overdiagnosing. But this is the presence of experiences that are reflected in those diagnoses. This isn't diagnosis. So you can see those rates have risen faster than any of these other conditions. And that is also reflected in service demand. So on the right-hand side, we see referrals to children's mental health services over the last 8 years or so, up until 2024. And you can see in the red line there, the sort of steadily rising demand. In fact, just about trebled demand since 2016 to 2024 in terms of referrals to children's mental health services. So we face a really challenging picture in delivery of health services, and the service that we have grown up with over the previous decades is one that is primarily focused on acute episodes of illness and responding to those using acute hospitals as the primary mode of delivery. The contention of the 10-year health plan is that can't continue, that model. And the new model that is signalled is one, exactly as you said, Roman, that includes these 3 shifts. So the purpose of the 3 shifts being to attempt to close that demand capacity gap in a new way, moving more emphasis onto prevention in addition to treatment, moving more of our services into community settings closer to home, and away from hospital settings, which are more expensive and may not be indicated in many of these sort of longer term management of long-term conditions, rehabilitation, that sort of approach. And crucially, shifting far more of our care into being supported through digital technology, and in doing so, again, maximizing the capacity that we have to deliver healthcare. So these shifts designed to both manage demand down by tackling a more preventative approach, but also increase capacity, for example, through digital, releasing more time to care. And alongside that sort of broader demand capacity picture, we have some really significant gaps in treatment. And in mental health, we might summarize some of them like this. For children and young people, less than half of those with significant mental health needs are having any contact with mental health services. Anxiety and depression, we have a world-leading service in NHS talking therapies. Despite that, that is seeing less than 15% of those with anxiety, of adults with anxiety and depression in the community. And in severe mental health problems, so conditions such as psychosis, bipolar disorder, and eating disorders, less than 3% of those who are already in contact with mental health services receive a NICE recommended psychological therapy. Less than 3%. So there's this huge gap in treatment alongside that demand capacity gap. And one way of thinking about this is that these are sort of needs that haven't even become demand yet. They're known that they exist in the community, but they aren't necessarily people on a waiting list that can be seen. This is just a sort of a lack of accessibility. And we need to sort of very much build this into our thinking as we go forward with the plan. So what are some of the opportunities and challenges? Well, the 10-year plan was published in the summer and it's called Fit for the Future. And I'm going to summarize some of the key components of it with a particular flavor of psychological ways of working and psychological professions. So I'll organize this around the main chapters of the plan. So the first chapter makes a very clear statement, and the statement is the NHS stands at an existential brink and it's change or bust. So very robust talk about needing to shift in how we deliver care. And by the way, this wasn't an entirely sort of government-driven approach. There were 250,000 contributions to the consultation that led to the publication of the plan. Many of you here may have made a contribution to it, in which case, thank you. But the plan, as published, does signal this new model of care organised around the 3 shifts. And as you mentioned, Roman, the goal to narrow health inequalities being a sort of golden thread throughout it as well. So then the next 3 chapters of the plan are the 3 shifts, and there's a lot in there to dig into. I do recommend you have a thorough read, but I've picked out some of the key components that relate to psychological practice. So as you mentioned, Roman, neighbourhood health centres, referenced in the budget, these to be sort of open 12 hours a day, 6 days a week, and bringing together that sort of community offer of healthcare in neighbourhood footprints of about 60,000 population. So these are quite small units of healthcare. But the idea being that this is a much more efficient and lean way of providing that sort of ongoing support and treatment and rehabilitation around these kind of more long-term condition type of issues. Alongside this, 85 new mental health emergency departments. So these are resources to enable those with mental health crisis presenting in emergency departments as a more appropriate setting with more appropriate way of responding to those needs rather than in a bay with a curtain around you. So that's an important sort of piece of investment that's coming and is being sort of actively rolled out now. We also have this piloting of neighbourhood mental health centres. These are 24/7 hubs, again on that sort of neighbourhood footprint, 60,000 population. And as you mentioned, 6 of these are currently being trialled, and there's capital funding to support the development of those across the nation. So then we have analog to digital, and I think this is going to be something we just are talking more and more about over the next years. And I think where we'll see some radical changes and transformation. So the plan commits to the NHS app effectively becoming the front door for healthcare. So having significantly increased capabilities around checking your symptoms, booking appointments, referring yourself, a service that's highlighted in the plan for early adoption of self-referral through the app is NHS Talking Therapies, but also the app being a place that integrates your patient record from across disparate strands of service you might be receiving. The app also to include a sort of repository for digital services, including mental health apps that are NICE evaluated. So that work is also sort of starting to unfold now. A couple more areas. in the digital transformation, online hospital. This is going to be an entirely new NHS trust that takes a sort of primarily a sort of digital by default approach that offers remote specialist appointments. So instead of being referred to your local hospital, you can choose to be referred to the online hospital. There you will sort of see a specialist remotely, and you'd be connected to sort of local diagnostic hubs and tests, etc., as needed, and only go to see specialists in the sort of physical estate if that was necessary. And the idea being this will be a choice, an alternate pathway that you can choose to take. And there's a discussion at the moment about how psychological ways of working and mental health might form a part of this offer. And perhaps the technology with the most immediate and significant potential is ambient voice technology. And where this has been trialed as a way of allowing a sort of different method of recording patient notes, the estimates are that it increases time for clinical practice by about 30 to 40%. So imagine a world where there's no more stopping and writing notes after a session, where that is taken care of by ambient voice technology. Your task as the clinician is simply to check that is appropriate, and all of the sort of information governance, confidentiality issues are taken care of successfully. That's the world that's being envisioned through this plan. And then sickness to prevention. So a lot of the action here is really going to be in departments other than the NHS, other than health and social care. For example, through the legislation on smoke-free generation, on changes to the sugar tax, enhancement of the sugar tax. But there are sort of health service elements to this that are going to be very important, particularly genomic testing. But and really important that the focus here remains on social determinants of poor health. And I think that's been a sort of significant challenge for successive governments, is to maintain that focus. But it needs to be, absolutely. We know how important it is. But also in sickness to prevention, there's an opportunity to really focus more on that sort of secondary prevention, so early intervention. Examples of this include the mental health support teams being rolled out in schools, with a commitment to complete that rollout by 2029. Young Futures hubs also being planned to help to tackle that sort of significant rise in mental health need amongst young people. And so those are the three shifts. The three shifts chapters aren't the only chapters of the plan. There's all of this too, and I'm not going to go through these in detail, but I want to highlight a few areas that I think are particularly significant. So the new operating model, chapter 5, sets out sort of how the NHS for this next period is going to work. There will still be a centre despite this current merger of NHS England and the Department of Health and Social Care. So there'll be a national setup. There'll be regions that support that. There'll be integrated care boards, which are effectively the commissioning arm of the NHS, and reduce some of their previous functions that we saw until this government came into power. And then providers will have a significant level of autonomy in delivering against the strategic plans. Quality is a really important chapter, and I really sort of think it's significant how the extent to which this stresses the importance of patient voice. So patient voice in driving our services, but also radically a commitment to patient-reported outcome measures being reported across all services by 2029. We're a very long way from this at the moment, so it is a radical commitment, and one that I think will serve psychological healthcare very well. This chapter also commits to modern service frameworks across a number of different sort of pathways of work. So severe mental illness, as it's described, is one of those, but also dementia and frailty, cardiovascular. and there's likely to be a children and young people's modern service framework as well. And these will set out that sort of vision for where these services should be seeking to get to in the next decade. So very specific focus on those pathways. Chapter 7 is a workforce chapter, and this highlights that 10-year workforce plan that Roman referred to, and that's coming in the spring, and the staff treatment hubs work. That's starting to gain momentum. Chapter 8, we have that sort of visioning around where digital might go next, the use of AI being very sort of prominent in the plan, the genomics piece, wearables, etc. And then chapter 9, which might sound a little bit dull, productivity and a new financial foundation, but actually underpins all of this other change in a way that I think we're already feeling the effects of. So the first element here is eradicating deficits. In other words, the books have to balance at the end of each financial year. This is something that has actually never really been achieved in the NHS before, and so is a really significant push. So rather than each year rolling forward with a deficit that then gets sort of additional funding to bail it out, we're not in that position now. There's a very firm hand on removing those deficits each year. But with multi-year planning to help this process. So rather than what we have seen very often is a sort of single year of planning for the NHS, and that sort of the priorities for those plans only coming through very late in the day. There's a shift towards a much more early multi-year planning. In fact, we've seen the publication of the multi-year planning framework in the last few weeks as the first of these multi-year plans. And reallocation of resource to community, obviously backing up that neighbourhood shift. Okay, so I do think there's some really significant opportunities here for psychological healthcare, and it's really important that we grab those opportunities. I'll set out what I think some of these are, but you'll have your own ideas about what others are, and everyone will be coming at this from a different vantage point in the system. My top 3 are these. I do think there's an opportunity for really embedding psychological approaches in neighbourhood healthcare, so that shift doesn't just become about moving resources out of hospital into a community-based hub. It becomes about really delivering a biopsychosocial model of care. By doing that, I think we can make a huge impact on recovery from physical and mental health challenges, and in doing so, support the whole system to become more productive and effective. There's an example of this I'll draw your attention to. There are thousands of examples, of course, across the country. This is Dawn, who works as a specialist psychological wellbeing practitioner in the stroke service in Somerset. And that service really sort of connecting up people's rehabilitation from stroke with then the receipt of talking therapies and psychological interventions in a way that's fully integrated, supports people's recovery and management of post-stroke, and in doing so will be making sort of significant impact on that whole kind of demand capacity issue in the service. There's another great opportunity, I think, for us to grab hold of digital innovation as an area in which we can lead and excel. And the reason I say this is that as psychological professionals, we already have made great progress in developing digitally enabled psychological therapies. For example, here's the virtual reality headset being used by someone undertaking the game change intervention developed by the Daniel Freeman and the team at Oxford as an intervention for agoraphobic avoidance amongst those who have experienced psychotic symptoms. This intervention has had fantastic effects and significantly reduces the amount of therapist time that would otherwise be needed to support people to tackle those difficulties. We can lead the way, I think, in some of these interventions. And the third great opportunity is what I mentioned earlier about that commitment to outcome reporting. And the reason I think this is a great opportunity is I think it will show that many of our sort of interventions that we offer through psychological practice are highly effective. It will also help us to get even more effective. So the graph shown here is the graph of proportion of people recovering in receiving NHS talking therapies or IAPT services. This goes back to 2009. You'll see in 2009, the recovery rate was something like 36% amongst those receiving that service. It's now been on or around or just above 50% for about the past 8 years. How did it improve? It improved because we were able to see the results that people were getting, learn from the best, and improve those services that weren't achieving such good results by learning from those that were achieving above average results. Equally, within the interventions themselves, using this sort of method of feedback direct from patients to ensure that intervention is tailored to their needs. So there's a great opportunity for us here, I think, demonstrate the value of what we're able to offer. But there will, of course, also be some challenges, and there's 3 that I'm going to highlight. The first of these is that I think we're going to need to avoid competition in this world in which deficits are being eliminated. There are real challenges and pressures that mean that it's less easy than it used to be to create new posts. There are some challenges at the moment on recruitment across the board, with sort of recruitment controls in place in many services. In this environment, it's going to be super important that we're working together as psychological professions for this joint goal of making healthcare more psychological, rather than reverting to perhaps what we've sometimes been guilty of in the past, which is shouting for our own bit that we particularly know about or work in, and that becoming sort of a bit competitive and undermining of people who are championing another bit, even though we've all got the same goals. So let's hold in mind that bigger, broader goal of making healthcare more psychological. One way in which I think we've addressed this over recent years is through the sort of work we did around creating a shared vision for the psychological professions through this process called Psychological Professions into Action. If you want to sort of dig more into that, have a look at the Psychological Professions Network website. Second challenge, I think, will be getting into the right rooms to influence what happens. So we're in this big process of change. It's in such times, the biggest, most powerful voices may have the strongest say. And so we're going to need to sharpen our elbows and get into the right conversations to make sure that what we can bring is really known about and used to the max. One way of doing this, I think, that helps to bring those voices together and get into the right rooms is through the Psychological Professions Networks. This isn't an alternative sort of professional body. It's a very different function. It allows us to work together across all of these different psychological professions and be part of building that bridge into talking with policymakers, etc. So if you want to be part of that, I would recommend you join your Psychological Professions Network in your region. It's free, it's open to all. And the third challenge, in a way, I think the biggest risk of all of this is that we might not change enough. If it is true that it's change or die, let's change. Because I think there's a great opportunity actually to make things better, to bring our services to more people. But if we sort of remain, if we get stuck in our sort of traditional ways of doing things, we may not change enough to be part of that. And here's an example of a great change, which is the deployment of mental health support teams across all schools in the country by 2029. Here's an education mental health practitioner working with a young person in one of those teams. It's transformative of young people's lives, and a great opportunity for us to sort of get on board with that and push it. So what next? And what next, particularly for psychological healthcare? Well, we've grown really significantly. I think Roman mentioned the 65% figure from 2019 to 2024. If you look back a bit further, back to 2016, you'll see that we've actually grown by about 125% since then. So more than doubled the psychological professions workforce. We're 34,000 in number now. But now as we go into this next phase, which might not be about rapid growth, it might be about consolidation. We need to make sure we provide the conditions in which all of this wonderful, rapidly growing workforce are able to stay and make a full contribution and be valued to do so. And there's some signals, I think, that this will be supported by the multi-year plans that are coming forward. So we have had the multi-year medium-term planning framework come out a couple of weeks ago. It's got 3 or 4 sort of key priorities around mental health. 2 of those are specifically about psychological professions and psychological practice. So this is really significant. The 2 that are specifically about psychological practice are the mental health support team rollout and NHS talking therapies expansion. But the planning also has sort of very clear commitments to rolling out a new approach to suicide prevention, which is more formulation-based rather than prediction-based, to autism and ADHD assessment, and to reducing admissions to mental health hospital. All of these areas where we're going to need a sort of major presence from psychological professionals and psychological practice. So even though not everything can be named as a priority, I think these are really important signals of the broader commitment to psychological practice as a way forward that needs to be prioritised at the moment, and hopefully can be the momentum that will also then be used to help us drive forward across all of our areas of work, all of which are important. We have the 10-year workforce plan coming, and it does really already, in how it's being trailed, signal a new approach to workforce planning. So this is from the 10-year health plan. The workforce plan, rather than saying how many staff do we need to maintain our current care model, which was what drove our previous workforce planning, it's going to be asking the question, given this reform plan and the commitment to a sustainable NHS, what workforce do we need? So in other words, if you really maximise use of digital, if you push resource out into the community, if you focus more on prevention, what workforce do you then need? Well, I feel clear that we still need a very psychologically orientated workforce, and that will remain a continued important element. But it is a very different starting point than saying, how do we carry on growing as we have in the past? But we've got some great ingredients to throw into this mix. So here are our 17 plus psychological professional groups, all making unique and important contribution. Increasingly now, I think, thought of as a single grouping of professionals representing the sort of fastest growing group actually in healthcare and the second largest group in mental health services. So we've got a lot to bring to this conversation about how we make this work going forward, but it will need our help, our leadership to decode all of this. You know, this looks complicated. All of these groups have their own sort of registration requirements, scope of practice, governance arrangements that will need our leadership to help the system to make best use of all of these groups. And in doing so, I think it's going to be really important that we remain focused on the fact that there are a number of different areas of psychological practice, all of which are important. So I think sometimes our conversations about developing services, growing our workforce have been focused, you know, in a segmented way on part of this picture. I think we need to keep the whole picture in mind. In other words, that psychological practice includes work to shift environments to be more psychologically informed environments, that a lot of our sort of different occupations will be able to offer psychologically informed interventions, but that's rather different to the specific model-based therapies that have particular governance arrangements around them, supervision requirements, etc. And that on top of all of that, in areas where there isn't any sort of particular evidence-based guidance or nice recommendations, or things are really complicated, it's going to be important to work from first principles, formulation-based, in a more sort of bespoke psychological practice way. We need to keep that whole picture in mind in moving this forward. So there's a lot of potential here, I think. There's a lot of potential still for a sort of positive, very positive future for psychological healthcare as we move forward with this new 10-year health plan. But I think we'll only realise the benefits of it if we all work together and get involved. So I would really recommend that you continue to get involved beyond this webinar today. One way of doing that, as I say, is through being part of the psychological professions networks, as well as through professional bodies such as the BPS. So I'd recommend you get involved in both ways. And I'll stop there, but look forward to our Q&A panel later. Thanks very much. Back to you, Roman.
Thank you, Adrian. Thank you for a really helpful overview of the Fit for the Future 10-year health plan. I think that was really helpful to kind of the way you broke it down to the different chapters, and hopefully we'll give people some kind of ideas to take this forward and as you said, read the plan, because actually there's an awful lot of content there, awful lot of relevance to all of our work. And then, as with all these things, it's the detail that's really important to try and get to terms with. I think it was also really helpful to hear your thoughts on opportunities for psychological professions moving forward, as well as the challenges that we may potentially be facing as well. I think those sort of three ideas you gave for both of those really kind of made me think through about what we need to be doing within the BPS, but also as psychological professions across the board as well. So really helpful. Thank you so much. And there are questions popping into our Q&A chat box. We'll come to those, as many of those as we can at the end. And I would encourage people to keep on putting those questions in, because if we can't answer them today, we'll find out some way of providing answers to people for those questions on the website, perhaps, or check with the policy team on that as well. So thank you, Adrian. And I'm going to now move over to Liza. And Liza is going to talk about the role of psychological professionals in system transformation. So over to you, Liza.
Thank you. Yeah, that's really and lovely to hear from Adrian there as well. And so I'm here today in my role as chair of the DOP. So my slides are going to be much more kind of broader workforce, not just the psychological professions workforce in this area. And I won't linger here too long in terms of what the three shifts are. We've heard a lot about those. And but what I will say is that not only am I here as chair of DOP, but I spent 15 or so, maybe closer to 17 years in the NHS myself, working in a variety of roles within and around the HR profession. So whilst I'm a psychologist by way of training and background, I spent a good deal of those years in the NHS HR field. Most latterly, actually, in one of those NHS commissioning arms that were originally, when I started, were called primary care trusts, which were then split to be primary care commissioning, which then became NHS commissioning organisations and are now becoming ICBs. And one of the things I will say as I start this, and we're still looking at these three shifts, is that, to Adrian's point about embracing change, it's going to be absolutely essential that everyone in the NHS embraces change if this is going to work, because it's really easy to be cynical about these changes. It's really easy to sit in the NHS and think, oh, this again. I remember in 2012 when we shifted to the NHS commissioning support functions and we'd split out, and the primary care trust had closed and everything had moved again already. And just before that, not long before that, we'd moved I was part of the changes that moved public health to local authorities, for example, and that felt like a shift away from the core principles of the NHS at the time. And then as we came into those commissioning support units and GPs were just getting hold of the reins of things and starting there to ramp up in terms of taking over the commissioning parts, it was really easy for people to say to us as we were going around and tupping people into different organisations, oh, it's this again, is it? We'll go back to health authorities one day. I'll just get a new badge, will I? And not think about it as really what does it mean for strategic and tactical change in the NHS. So I would just encourage everyone to do exactly as Adrian has said, and to really sort of embrace what that means, because these changes, these three shifts, are not going to be easy. Because NHS is one of the largest employers at the moment, but it's an employer that carries significant vacancies. And whilst those vacancies, I understand, have been coming down, and I've looked at the data from NHS England over the last year, and thinking about, and I think the IFS have also had a go at the Institute for Fiscal Studies have also had a go at looking at this. There are a large number of vacancies. The vacancy rate back in, I think it was March or June, it was 30th of June, sorry, I was looking at, was still 5.9% across the, again, NHS England locale. So not looking even at the devolved areas yet. And that's over 100,000 people. And that's over 100,000 opportunities that you have actually to reshape the workforce, because as Adrian quite rightly pointed out, there are freezes in place, there'll be restrictions and controls in place, and the NHS will be seeking to use those vacancies to maybe push through some of the reformers we've seen in previous large-scale change programmes. So it's getting better, but it's still fragile in terms of how it looks at vacancies. And this whole shift in terms of community care out of hospitals requires a different set of skills. I remember, again, I was part of the NHS when we had this before, and I think the big one at the time was the shift in obesity pathways and where that was going to be managed and how that was going to be managed in community. That was just at the time I think social prescribing was coming in, so we were looking at a shift towards that. And actually, you can't just take a nurse out of a ward at a band 5, 6, 7 and put them in the community. It's a different set of skills, it's a different set of interactions, and it's a different set of nuance in terms of how people are working and where they're working. Not least, if I think about it at a very tactical element, when we're talking about supporting people to make changes in the workforce, you go from being on a ward, for example, where you've got shifts and you're on a shift with 10, 12, 20 people, depending on how big a unit you're working on, to maybe meeting up with your team once or twice a week. If you're lucky, maybe it's once or twice a month. If you're not lucky, if you're fully community based, these are very different ways of working. So we have to think about how we're going to support people to do that. And really, I think that's where I come in terms of the DOP and representing sort of occupational, organisational, business psychologists, however we want to describe them, is thinking about what are those both strategic and tactical changes that need to be made when it comes to supporting this kind of reform within the public sector. And Roman also alluded to this first point here, really, which is about that workforce well-being and what do we do to make people want to stay? How do we help people want to stay in the NHS despite all of the changes? How do we help them to not be cynical or to allow it to burn them out as a result of going through yet another change? For some people, it'll feel like probably they've never had a chance to get off that merry-go-round of change. So how do we do that? And both occupational psychology, but also other forms of psychology, workforce within the BPS, can really start to look at what are the evidence-based stress prevention, what are models of meaningful work? And by that, I mean, so this point I just made about the change from being ward-based, for example, to community-based in terms of how service is delivered. How meaningful is that to you? If part of your values, part of what you like about work, part of what you value about the workplace is being part of a team and interacting with your colleagues every day. So how do you still make that meaningful when you're out in the community or when you're based somewhere else or in a health centre where maybe you're in a much smaller environment? So how can we help people to feel and find that there is meaning in the way that they work, as well as the work that they're actually doing? How can we make sure that there is psychological safety and burnout mitigation? So how do we help people have a meaningful voice? So again, to Adrian's point about the patient voice being important, staff voice is also really important in these kinds of change. And how do we help people to feel safe to say that? And I don't mean just feeling safe to speak up without fear of reprisal. I also mean feel safe to speak up because contributing feels like it means something and something comes back from that. Not just shouting into the wind, as I've heard colleagues call it before, both in my time in the NHS and even now when I'm working with other types of client. So this is all about how do we make sure there's better job design? How do we make sure there's enough autonomy? And Adrian talked about that, providers having much more autonomy. So NHS providers having much more autonomy. How do we make sure staff also feel that way as well? How do we make sure that there's retention drivers that are based on behavioural evidence? Because again, and I don't want to sound overly flippant, but I think it's worth worth doing that to an extent to just highlight the point, which is, we've all seen over the years. I remember again, in my time in the NHS, and even now, people talking about how exciting it was that Google put in, free food and bean bags and things like that. All of that is great and it sounds fun and exciting, but actually, does it actually help well-being? What are the sorts of things we actually need in place to support staff well-being at times like this? And then there's these more strategic as well as tactical issues that we need to deal with. So at the strategic end, we've got the culture and change at scale. How do we make sure that organisations are ready? How do we make sure that there's good use of behavioural diagnostics to understand where organisations are, what they're doing, and how prepared they are for that move, both at the leadership level and at the full workforce level, at individual contributor level? How do you make sure that you're putting new practices in high pressure environments in the right way, instead of it just feeling like something else? And one of the things that I remember talking about extensively when I was an HR director in the NHS is how we never say no to anything. So you've got 50 KPIs, let's say. It was always more than that, by the way, I'm aware, but let's say 50 for argument's sake. And then a new government comes in or a new Secretary of State is appointed for whatever reason, and they add another 20 to that. And no one ever says, actually, do we still need those other 50? So how do we make sure that when we're embedding new practices, we turn off old ones? How are organisations taking that forward? And again, these are things that psychological professionals can help with. And there are plenty of them in public sector and that can help do this. And again, this identity shift here in terms of culture change, I'm not sure that's something that's ever always worked. I don't know whether that's truly been achieved as we've seen change after change. As I say, I remember back in 2012, the big shift that came of moving to sort of the GP-led commissioning that led to commissioning support units. When, as I say, even further back than that, when public health went out to local authority, have we really understood what that means for our identity as professionals? How do people feel about that? I remember certainly in commissioning, when we moved to commissioning support and it was separated from provision, even at the primary level, people were saying that were left in commissioning units then, I feel further away from patients than ever. So how do we make sure that everybody working in the NHS feel connected to patient in order to deliver on this kind of reform? And again, we can support with that kind of thing. Then I won't cover too much in terms of the behavioural science for prevention and public health. I think Adrian covered a lot of that off, so I'll perhaps skip over that and talk about team effectiveness and multidisciplinary working. Again, thinking about how do you make this work in this environment, given that the very tactical issue and the very hands-on practical nature of the fact that there are multiple organisations, legal entities within the NHS. And this talks to Adrian's point, I think, about competition and how not to be competitive, not just on a workforce issue, not just on terms of who gets what role and where, but each organisation has its own budget, its own chief exec, its own chair, its own board, its own set of regulations, its own set of KPIs. How do you make sure that those organisations are really working together for system level change? And we hope that the ICBs will help create part of that. We hope that they'll start to gather that kind of momentum behind system level change. But this isn't the first time the NHS has talked about systemic change and systems thinking. In fact, I think there are many, in fact, Adrian and I may have even been on some of those same conferences and work events around systemic change back in the day, right across Hampshire, Kent, Surrey and Sussex. So we need to really think about how do we as psychological professionals make sure, again, this is about how teams are designed, how the governance, the agreements, the rules of practice are laid out to support teams to work, not just multidisciplinary, but multi-organisation as well, because there will be conflicts and there will be communication breakdowns. So how do we help people to manage that and to support each other during that time? And so where I think that we can support that is as both a DOP professionals, but the wider BPS, we need to remember that it's not just org and ox psychs that talk about how organisations work together and how people work together, but how do we make sure that roles, teams, and services are really grounded in human factors? How do we embed behavioural science into population health and prevention? We can support people with digital adoption and behaviour change. There's so much information coming out and so much literature now around why people may be cynical again about adoption of digital innovation, for example, not least because there is some excellent literature around generational trauma when it comes to mistrust in healthcare professionals. So where we have seen in the past certain ethnic minorities, for example, being tested on in unethical ways in the past. Now, when something is about innovation and doing it for future good, there is undoubtedly some generational trauma that exists with that kind of adoption. So how can we support individuals as well as organizations to mitigate some of that and to support people through that, to be less worried, less fearful? But also here, in terms of both the culture change and supporting a digital adoption, talking about transparency, talking about using ambient voice technology, for example. How do we stop people being fearful in the workforce that that's just another way to catch them out later when someone complains? You know, maybe it didn't capture what you said right. Maybe it didn't have the right tone, and or the tone that it captured. I mean, we've all written those emails ourselves when you're not thinking, and someone reads it back with an objective set of eyes, and you think, God, that's not what I meant at all in those. So how do we prevent that kind of fear in adopting those kinds of digital innovations? And that extends to the culture change as well, and leadership development. How do we create and set up leaders for success? And I saw a comment pop into the chat. One of the questions was about 8Cs and above, so managers. There is still so much talk, and there was so much talk when I was part of the NHS around wasteful management practices, wasteful managers, too top heavy being in the NHS. But quite rightly, one of the questions is, well, how have we got enough people to actually support that growth? Because nobody wants clinical staff taking on all of that admin work to create leadership change as well, to create systems change, or to do more of that paperwork. So how do we make sure that the leaders that are there are set up for success? How do we support them to deliver on the things that are right for them to deliver on, and allow those to tactically deliver healthcare in the best way possible that should be tactically delivering healthcare? And we've already talked about kind of self well-being and retention. So our call to action really is around, how do we embed psychological expertise into all of these things? I'm quite taken by the fact that the first thing is that we've got a workforce plan coming out a lot, sort of several months later, if not half a year later than the actual plan came out, because one of the change management 101 practices is to have all of your ducks lined up in a row, and that includes the plan for your workforce. So I would ask, our call to action would be, please let psychological experts in this area be part of those processes when it comes to workforce planning and redesign, because it is about the job, it is about the systems, it is about the processes. Make sure that we're part of the conversation on change, as well as those evaluation frameworks and community-based service redesign. So these are areas we can support right across this spectrum. I'm going to stop there. I know that was hasty, but I want to make sure that I leave the right amount of time for Q&A. So Roman, back to you.
Thank you, Lisa. That was really, really helpful. I think it really complemented Adrian's presentation. I think some of the areas you picked up on kind of overlapped, and you kind of pull things out. And I think from an occupational psychology perspective, it was really interesting to hear that. And from your experience in HR, in the NHS, going back all those years, I think it was really helpful to get that context as well, that we've been through change before. But we shouldn't be cynical about change. We need to embrace change, because this is actually really a major shift, isn't it, forward from where we've been in the past to where we are now, to where we have to be, because the NHS needs to be fixed, and it's not going to carry as we are. We're not going to get to the place we need to be to actually improve the lives of people who so depend on the healthcare that is provided. So thank you so much. That was really, really, really interesting, and really very, very helpful as well. Right, so we're really bang on schedule. This is amazing. We've got the last 15 minutes with perfect timing. So thank you both for your presentation being so timely. We do have an awful lot of questions, and I don't think we'll be able to get through all those questions, but we'll certainly try. I'll go through and take them from the top, and see who can who'd like to answer the questions. So the first two really are around counselling psychology. How will the developments influence the professional field of counselling psychology specifically? And linked to that, is there anything currently being done to support trainee counselling psychologists in accessing funded placements, particularly given that many of our NHS placements are unpaid, despite the significant influence these roles have within the NHS services? So either of you got any thoughts on counselling psychology and training and funding? Adrian,
shall I kick us off? Yeah. So, I mean, thanks for the question. To be absolutely clear, counselling psychology does play a very important part in health services and needs to continue to do so. And we are in a position where the sort of there's a historical disparity in which professions have funded training and which don't. I think the first thing to say is I know there are examples of counselling psychologists being employed during their training, and that sort of employment then leading to a sort of qualified post at the end of the training. That is locally driven at the moment, and so there are services I know adopting that approach. I would love to see us get to a place where there is reform of sort of funding policy nationally to enable the right sort of support to support that pathway for counselling psychologists specifically. That is an ongoing conversation that we're having nationally. So there's nothing I can sort of feedback on that right now, but in more detail, except say I would support reform. We're working on that.
Great. Okay. Thank you. Thank you, Adrian. Is that okay, Lisa? Do you want to add anything to that, or is that?
No, I think that covers it. Thank you.
Thank you. Well, the next question. As there has been a 65% increase in psychological workforce, do you have any data on whether there has been an increase in senior 8C posts or above who can coordinate, manage and oversee this growth? And does the DOH or DCP have any standards for the minimal levels of senior posts in NHS services? So obviously you alluded to that one, Lisa, in your presentation. Would you like to answer that, or would you?
Yeah, and I don't know that I can answer. I haven't seen the data broken down to that level, and possibly because I'm not in the NHS anymore, I don't get access to that level of data, so I can only see what's publicly available, and I'm not sure if that's ever sort of distributed. I think previously I would say, and Adrian can correct me here if things have changed since I left the NHS, but there was never really any standards for senior post ratios to the rest of the staff, other than the sort of the lovingly referred to as the Daily Mail test in HR circles in the NHS quite often, which is would it put people off and would it cause a negative headline in the tabloids if people saw how many managers we had or how many of a certain kind of worker we had? So and that's normally where you then, as I alluded to, get these sort of negative stories. But I think what we need to be careful of is setting arbitrary ratios for managers, because you've got two ways of looking at this. There's the managers that you bring in and are permanently part of your workforce, and there might be those that you bring in temporarily while you're making a change to support that change as it moves over. And at the moment, the NHS has a couple of choices, like it always has had, which is at times of big strategic change, do you temporarily stock up your workforce or hold on to people that might otherwise have been moved on in order to do that? Or do you go back out to the big four consulting houses like we always do, KPMG, PwC, Deloitte and McKinsey's, to tell us how we should do things, who come in, write lovely reports, leave that with us and then go away again? And who have you got to sustain those changes? So I think rather than thinking about it as ratios, it's about really looking forward as part of that workforce plan to say, what do we need in this area? Who should be doing the work so that it's meaningful to everyone as they deliver? And then putting those right people in place, whether that's permanent or temporary, but putting the right people in place for those jobs.
Okay, thank you. That's a helpful perspective on things, certainly, and it fits in with some of the things that were said earlier on about how it's not about how many, but it's actually what needs to be done to fulfil the roles. But in terms of how many, Adrian, do you have figures on that? Because I think that you.
Yeah. So I mean, I'm taking it that the question is about psychological workforce, because that's in the sort of beginning of the question. And of course, the first thing to say is it is really important that there's the right sort of supervision and leadership for this massively growing psychological workforce that we've got. However, the workforce has grown with a large emphasis on a number of new roles that don't typically operate in the same sort of scales as our traditional workforce going back 20 years. There was 95% clinical psychologists. We're not there now. We have a number of roles whose typical deployment is at band 5 and band 6. So of course, this sort of overall hierarchy pattern of workforce grades, this distribution will have changed, and it has changed. But I did just look this up in response to the question, and our overall workforce has grown 120% over the period. Band 8 and above workforce has grown by 63%. Band 8C and above has grown by 35%. So they've all grown. I guess, we're in a position where we do have more roles that occupy that sort of band 5, band 6, band 7 sort of area than we did in the past. But we need the right sort of pyramid to make sure that the whole workforce is supported and supervised.
Right. Okay. Thank you. That's helpful to have those figures, definitely. Right. Let's move on to the next question. This is a specific question around Chapter 2. For the new services mentioned in Chapter 2, are they for child or young people, adult or older adults? Does that make sense to you, Adrian?
I'm not sure which are the new service. I think this probably means the sort of neighbourhood focused services, so the A&E, mental health A&E departments, and the 24/7 hubs. So it's a mixed picture. So the A&E mental health departments, some do have a sort of children and young people's component. Not all of them do. It's being very much locally developed to kind of plug the sort of local need rather than a sort of top-down driven national approach. So some will, but in other cases there will be more appropriate provision for children and young people already. The 24/7 hubs are typically adult at the moment, and I'm not aware of there being a sort of CAMS component. So I think that's more of a sort of adult development. Of course, the broader neighbourhood push of moving care out of hospitals into the community is an all-age push. So we'll see that sort of cradle-to-grave service shifting more from hospital into community.
Right. Okay. That 60,000 population is children and adults in total, and is it based on that sort of?
Yes, I believe so. I believe that's how it's calculated. Yeah.
Adult only number. It's a broader thing.
Yeah.
Which is a real challenge, isn't it? And that's a sort of a relatively small number.
Yes, it is.
Really. Okay, thank you. Thanks for that helpful answer. The next question is quite a long question. I won't read the detail, but the punchline is: how does the NHS plan to incorporate practice-based evidence more meaningfully into clinical practice and into its wider frameworks and systems?
Should I lead off on this?
Yes, please.
So evidence-based practice, I think, is often misunderstood as meaning NICE recommended care or only a sort of specific narrow set of treatments being delivered. Evidence-based practice, of course, means the sort of combination of research evidence, clinical expertise, and patient choice. So when you bring those three things together, I think that means you have a means of deploying what we do know works for most people, but in a way that's appropriately flexible and tailored, depending on sort of individual need. In that scenario, I don't think there is this sort of same dichotomy between evidence-based practice and practice-based evidence. So I prefer not to split those things, but to see them both as part of this broader evidence-based practice picture.
Okay, thank you. That makes sense. Thank you.
Can I just add to that in terms of the rest of and the wider sort of workforce from a psychological point of view. So when I think about kind of what we do as OCPsychs in the profession, for us that also means incorporating evidence-based practice. So and this is where I worry and have worried over the years is sometimes when you are using things like the big four consulting houses within that, you're not always sure where their evidence is coming from and what they're basing that on. So whereas at least when you're working directly with organizational psychologists, those who are registered, those who are chartered, you know that there are a set of standards that we adhere to as well, that through the BPS that talks about actually how do we bring together evidence-based practice.
Okay, that's again a helpful perspective there. Thank you, Lisa, and thank you, Adrian. Next question around ambient voice technology. Does ambient voice technology rely on artificial intelligence? We talk about the importance of reducing our carbon footprint, and we know AI contributes to significant consumption of electricity and water. If there's a use of ambient technology that relies on AI, how are the government going to mitigate the environmental impact of this? Now, we obviously can't speak for the government here, but in terms of ambient technology, Adrian, is that one that you want to?
I think what I would say is that it's a very important point, and obviously these things do need to be brought into balance and considered really carefully, and that is a cross-government approach that's going to be needed. I think there's other sort of strands to this that are relevant, like if we can enable our workforce to help more people to get better through the use of things like AI-driven ambient voice technology, then that also has a positive impact on the economy that can help to drive our sort of carbon neutral goals, etc. So it's complex. It will require a sort of cross-government approach, but we absolutely need to keep this in mind and keep that as part of the conversation.
Okay, thank you, Adrian. Liza, anything to add to that?
No, I don't try and judge what the government are working on that.
Okay. Next question. We're doing okay for time for a few more minutes. In regard to long-term health conditions and physical health condition, how will psychology be more integrated into these services?
Yeah, so I mean, this is a massive untapped potential for the psychological professions workforce. That is really clear. And I do think we have a moment of opportunity now to influence that as we move to these neighbourhood resources, neighbourhood teams. It's not a given that we'll achieve everything we want to there, but I think by working on this together, pushing on this together, and being clear what we can offer, there's a great chance here to make a bit of a step change. I mean, one of the things that will win this argument is the economic case. At the moment, that's a very powerful argument because we face sort of unprecedented challenges in funding our health service to meet the level of demand. If we can show how a psychological approach integrated into and across our services helps people to recover, have good quality lives, but also, where appropriate to them, contribute to the economy, that will help to sort of sustain and expand that input of psychological professions further. So there's an important bit of health economics work there to do. I think some of that has been done around sort of long-term conditions and talking therapies, but there's a lot more to do there to show how integrating psychological approaches impacts positively. I think the argument is there to be won.
Okay, thank you, Adrian. Liza, do you want to add anything to that?
No, I think Adrian's covered that nicely. Thank you.
Okay, we'll certainly have one more question at least. So how are services expected to staff the new services and changes within existing services when across many NHS trusts in England, there are currently voluntary redundancy and severance schemes taking place and being extended due to not enough people stepping forward for them? Question, how are we going to be able to meet these objectives of the 10-year healthcare plan with such loss and streamlining?
And I'm happy to kick that off. So although I'm not based in the NHS right now, and I'm aware of that, so I'm not answering from the position of having seen anything or been part of any conversation on this. But what I would say is, in my previous experiences, that it is about getting the right people into the right places. So there will always be, with 1.5 million people across the NHS, there's always going to be areas that are moving down, other areas that are being ramped up. And that's the key thing. So when the 10-year plan for the workforce is released in the spring, that is the sort of the moment of truth, I guess, in terms of how and where are those shifts being made? What do those current things that are going on now, how do they help inform those future decisions? So as those changes are happening now, how does that inform what we need to do and where people need to be? And as I say, that's not just necessarily about numbers, because it's very easy to get down to a numbers game and be like, 500,000 work, headcount from here to 500,000 over there. But actually it's about what are the roles that are needed, what are the skills that are needed, and how are we going to make that happen and over what time period? Because those skills also don't magically appear out of thin air. And again, you may therefore see some areas being streamlined because those are not the skills we need for the future, and other areas being ramped up because those are the skills we need for the future. So I think it's difficult with so much redundancy talk going on at the moment, but we need to think about that as a balancing act right across a workforce of this size.
Thank you. That was really, really helpful to think about that sort of broader range of roles. The time has taken away from us now. It's a minute to go before we have to finish, so I'm going to have to wrap up the session now. It's been fantastic. I think really helpful. I think both of you for your presentations and also for answering those questions so thoroughly as well. So thank you so much for your contributions today, and thank everybody for their questions. We have another 13 or 14 that haven't been answered, unfortunately. So we'll kind of make a note of those and see what we can do to provide some responses and perhaps see how we can get responses from both of you. So I'm going to have to draw the webinar to a close. It will be available, it has been recorded, and will be available on the website in the next few days. So watch out for that. And thank you so much for your contributions, and wish everybody a very good rest of the Monday and rest of the week as well. Thank you so much indeed. Bye-bye.
Thank you. Bye.